Hi, good evening, everyone. Shivam, let's keep everyone else muted. Can we start now?
Yes, ma'am.
Okay. Hi, good evening, everyone. I'm Dr. Nisha Bhatnagar. I am the coordinator and moderator for this Young Turks Journal Club. This is an initiative by Indian Fertility Society. Future vision of our president and our secretary, Dr. Pankaj Talwar and Dr. Shweta Mittal. The idea of this is to read about new researches, present the new work, and encourage all the youngsters to come out with, whatever they have questions or they need guidance or to talk about the latest things happening in the field of infertility. I would invite Dr. Shweta Mittal to say a few words and ma'am, please come and start the session.
Good evening, everyone. Greetings from Indian Fertility Society. Greetings from Dr. Professor Pankaj Talwar, sir, who is President IFS, and I'm Dr. Shweta Mittal, Secretary General of IFS. The brainchild of Dr. Pankaj, sir. It was when I was taking over, and Dr. Pankaj, sir, asked me that, can you do all this? Will you be able to carry forward my vision? I said, yes, we can do that. And we thought that our young Turks are a very big population. Now we are having so many fellowship programs. We are having PhDs, we are having DMs, we are having loads and loads of, highly educated doctors who are getting into reproductive medicine. And this is the crowd, I think, who would come up with brilliant research. So what we thought was that this program is purely for the young Turks, by the young Turks. So all those who are below 45 years, who are interested in good articles. So we'll be bringing in new articles. It's like an ongoing education platform. And then what is our motive? I think the motive is that even if, including me, if I can pick up 1 or 2 points from any of the articles which we are presenting, and we can imply it in our, practice, and this is how we would be making our practices better. And we will also be updated with newer things, because in our normal everyday practice, it becomes very difficult to scan journals. So this homework we will be doing. So now I'm handing over to Dr. Nisha to start the program, and I wish them all the best.
Thank you. Thank you, Dr. Shweta, for kind words. And I think indeed that is the reason we are doing all this. And I would invite Dr. Bhavani. She is Associate Professor at Sir Gangaram Hospital. She is a FNB candidate and she is a very, very good accommodation. So, Dr. Bhavani, please present the journal topic to us.
Can the screen sharing be enabled? It's disabled at my end.
Done, ma'am.
At the end of it, I would request everyone to participate and ask a lot of questions. Okay. And also, the journal club is going to happen every second and last Friday. So the next person who's going to present, we would be happy if you announce, volunteer it here only.
And also, what we have decided, since today's topic is Dr. Manu there.
Yeah, Dr. Manu is going to join us.
We have brought in a very learned, andrologist, urologist from Sir Gangaram Hospital. So we decided that when we will be presenting, topics which will be even beyond our own domain. So what we will do is that we will be getting an expert so that we can have a lot of discussion. During the presentation, please put a lot of questions in the chat box and Dr. Nisha can take forward all these questions.
Yes.
Okay.
Dr. Manu is also there.
Thank you so much, ma'am, for the kind introduction. I shall now begin with the first journal club of Young Turks. The topic is Aphrodite criteria, addressing male patients with hypogonadism and or infertility owing to altered idiopathic testicular function. This was published in RBM Online very recently this year by a team led by Sandro Esteves. And the main research question was that, can a novel classification system of the infertile males stratify different subgroups of male infertility to help in designing clinical trials on hormonal treatment for male infertility, and to counsel and treat the endocrinological imbalances in men and ultimately increase the chances of natural and assisted conception? This was a collaborative effort between andrologists and gynecologists specialized in reproductive medicine with expertise in male infertility, which led to the development of the Aphrodite criteria through a consensus process based on clinical patient description and the result of routine laboratory tests, including semen analysis and hormonal testing. The critical questions that this review article intended to answer were that how can male infertile patients, mainly those with unknown causes, be classified to guide management? What is the importance of hormonal treatment for male infertility, and what are the current options and outcomes and limitations of hormonal treatment? Evidence referenced throughout this paper suggests that hormonal therapy may allow these men to achieve parenthood by converting the oligozoospermic male patients from IVF ICSI treatment to IUI, or even natural conception, and those with non-obstructive azoospermia to ICSI. Now, the 5 groups that were described under the Aphrodite criteria: Group 1, hypogonadotropic hypogonadism; Group 2, lower semen analysis with normal FSH and normal testosterone; Group 3, lower semen analysis parameters with normal FSH but reduced testosterone; Group 4, lower semen analysis parameters with elevated FSH and normal or reduced testosterone; and Group 5, comprising of unexplained male infertility in the context of an unexplained infertile couple. Now coming to Aphrodite group 1, which is hypogonadotropic hypogonadism, which constitutes 1.9% of azoospermic and 1.6% of all male infertility cases, characterized by reduced FSH and LH serum concentrations, reduced testosterone concentration, and lowered semen analysis parameters. Therapeutic options include GnRH pumps or exogenous gonadotropins with LH activity. GnRH pumps, as we know, are cumbersome to use, so they are not in much of clinical use. Several studies have evaluated the administration of gonadotropin therapy with HCG alone or in combination with FSH, with significant improvements in spermatogenesis up to 90% in 90% cases. Now, the therapeutic regimens typically begin with 1,000 to 2,500 units of HCG twice weekly for 12 weeks. HCG alone appears to be able to restore spermatogenesis, particularly in adult onset gonadotropic hypogonadism. However, in patients with congenital hypo or adult onset hypo where FSH levels are very suppressed, treatment must involve addition of FSH between 150 to 300 international units 2 to 3 times weekly up to 18 months. HCG and FSH have shown to achieve a better therapeutic effect than HCG alone for improving sperm concentration in some studies. However, the result is based on limited evidence and no clinical trials exist comparing the different regimens. Now come to Aphrodite group 2, characterized by abnormal semen parameters with normal FSH and normal testosterone. These include idiopathic infertile males with oligozoospermia or non-obstructive azoospermia with normal FSH and normal testosterone. This constitutes 50 to 60% of infertile males. The authors speculate that these patients might have relative hypogonadism due to reduced gonadotropin action. So the levels of FSH and testosterone are normal, but there may be reduced gonadotropin action in these patients. So 4 meta-analyses published so far indicate that FSH therapy in these patients with idiopathic oligozoospermia was associated with increase in sperm concentration, decreased DNA fragmentation, and improvement in pregnancy rates. In a 2023 review by Steves et al., couples with male partners exhibiting idiopathic oligozoospermia who received gonadotropin treatment had significantly higher natural as well as assisted pregnancy rates. The most common FSH include recombinant preparations given subcutaneously twice or thrice a week for 3 to 6 months in doses ranging from 75 to 300 units. Gonadotropin therapy has also been used to stimulate spermatogenesis in eugonadal non-obstructive azoospermia patients. However, existing studies are heterogeneous regarding the patient numbers, gonadotropin regimens, treatment duration, and follow-up. So more research is needed to accurately assess the beneficial effect of gonadotropin therapy in this patient population. Though this review mainly deals with the use of gonadotropins, the discussion in the review also makes a mention of the role of SERM, which is selective estrogen receptor modulators and aromatase inhibitor. And it has shown some evidence regarding these, that in a meta-analysis of 8 studies, treatment with clomiphene showed a significant improvement in sperm concentration compared with placebo. And the dose mentioned ranged from 20 to 50 milligrams for 3 to 6 months. And a meta-analysis on letrozole and anastrozole in patients with low testosterone to estradiol ratio, which are usually the obese men. Here also, there was a significant improvement in the sperm concentration and sperm count. However, on comparing all these drugs with gonadotropin, neither drug showed superiority in outcome. Now coming to Aphrodite group 3, which is characterized by abnormal semen analysis parameters with normal FSH but reduced total testosterone concentration. So this group comprises patients exhibiting lowered spermatogenesis and reduced testosterone concentration. This indicates a possible reduction, relative reduction again of gonadotropin action. So it has been suggested that the response to FSH therapy might depend on the genetic background of the affected men. Using real world data in an Italian study, it showed that following a mean FSH treatment duration of 9 months, 43 patients 94 with idiopathic male infertility showed significant improvement in sperm parameters and resulted in pregnancies. That is, 1 in 4 men became fathers with this FSH treatment. And in this cohort, 20% cases had low serum testosterone levels. So since intratesticular testosterone plays a crucial role in spermatogenesis, reduced circulating testosterone might indicate reduced LH activity on the testes due to local hindrance. Thus, it is plausible that these patients may benefit from a hormonal therapy which contains both FSH and LH. So the review by Esteves et al. On the use of hormonal therapy in these hypogonadal non-obstructive azoospermia patients suggested that hormonal therapy increased the success rate of sperm retrieval by TESE compared to the untreated patients. And the regimen it suggests is that the most common regimen used included urinary HCG alone or in combination with FSH, given 2 to 3 times a week for 3 months longer. Now coming to group 4, which is lowered semen analysis parameters with elevated FSH and reduced or normal testosterone. So most patients in this group are males with non-obstructive azoospermia with hypergonadotropic hypogonadism. Gonadotropin therapy using HCG and FSH has been shown to promote spermatogonal proliferation in these patients. And exogenous administration of gonadotropins might stimulate Sertoli and Leydig cells, even under hypergonadotropic hypogonadal conditions, providing an extra stimulus to the few tubules containing proliferating spermatogonia. Meta-analysis conducted in 2022 analyzed 10 studies in men with the non-obstructive azoospermia receiving various types of hormonal stimulation, and results showed that pre-treatment with hormonal therapy increased the surgical sperm retrieval rates, although the evidence was low quality. However, on subgroup analysis based on the type of non-obstructive azoospermia, patients showed a significant improvement in sperm retrieval rates only in normogonadotropic group, not in the hypergonadotropic group. Despite this, some studies have reported success in retrieving spermatozoa from the hypergonadotropic hypogonadal non-obstructive azoospermia group as well. Now, the various therapies that have been tried are HCG monotherapy, FSH monotherapy, or HCG followed by FSH treatment, and other combined regimens using clomiphene, aromatase inhibitors, and gonadotropins together. So currently the evidence is mixed, underscoring the need for further research to elucidate the precise impact of hormonal treatment in this group. Now coming to the last group, which is the unexplained male infertility group, which comprises 15% of all couples, infertile couples. This group comprises men with normal FSH, normal testosterone, and normal semen analysis parameters. Currently, these patients are not individually treated since the alterations are not detected in either semen analysis or the hormonal profile. Accordingly, their female partners are often treated in the context of unexplained infertility with ovarian stimulation, with or without IUI or ART. However, this group of male patients could benefit from FSH stimulation if a stimulatory rather than a substitutive therapeutic approach is applied. So, indeed, there is evidence that physiologically spermatogenesis does not run at its maximum capacity, and extra FSH may boost it further, resulting in improved sperm parameters, which could result in increased pregnancy rates. A more proactive approach is needed to explore this testicular overstimulation approach, starting with trials of higher FSH doses over longer periods of time. And boosting spermatogenesis above baseline should be regarded as something similar to ovarian stimulation. So just a summary of the suggested gonadotropin regimens under this review for each group. For group 1, which is hypogonadotropic hypogonadism.
Can you slowly now sum up so that everyone can, even take notes if somebody wants to?
Sure, ma'am. So group 1, which is hypogonadotropic hypogonadism, the suggested gonadotropin regimen is HCG, and FSH may or may not be added depending upon the type of hypo. In adult onset, HCG should suffice, but in patients with congenital hypo or adult hypo with excessively suppressed FSH, then in those cases, HCG with FSH should be given. The group 2, which is abnormal semen analysis with normal FSH and normal testosterone, in these patients, FSH alone should suffice. In group 3, which is abnormal semen analysis with normal FSH but reduced testosterone, in these patients, FSH needs to be used and HCG may be added to increase the intratesticular testosterone levels. Group 4 is the group with abnormal semen analysis with elevated FSH and normal or reduced testosterone. In this group, HCG needs to be given and FSH may be added. And the last group, which is the unexplained male infertility group, where everything is normal, semen analysis, FSH, testosterone, here FSH alone can be given for testicular stimulation. So the proposed Aphrodite criteria offers a standardized approach to classify patients with male infertility. They can improve communication and clinical management among andrologists and ART experts. And furthermore, they may highlight areas lacking data and promote clinical research to discover new pharmacological treatment options for male infertility. Thank you.
Thank you. Thank you, Dr. Bhavani. Very wonderfully presented. I would like to take the questions now. I think Dr. Manu Gupta is there. Sir, can you please switch on your video, please? There are few questions. So there is the first question is, when we are talking about testosterone, Dr. Bhavani, you can answer this. When we are talking about testosterone, is it free testosterone or total testosterone?
In this review article, they have testosterone.
Bhavani, you are on. We can't hear you. Is it free testosterone or total testosterone?
Ma'am, it's total testosterone. Am I audible?
Yes, you are. You are.
Yes.
So one thing also, if there is already high FSH, Dr. Manu Gupta, can you please answer this for us? Does high FSH is indicator of not doing TISA? If you have a very high level of FSH, does this mean that we should not go for TISA?
It's very difficult to find sperms on a simple TISA in a patient with high FSH.
Maybe it is easy to explain the prognosis to the patient. You can say that, we cannot say that with high FSH we will or
so
we
a
will
small
not find.
size small size testes with high FSH, the chances of finding sperms on TISA or an FNAC is very little. So in case we need to retrieve the sperms and the patient is well counseled, then we should go for a bigger procedure like a TESI or a micro TESI only.
Okay.
And so consider using hormone treatment before going ahead with micro-TESI in this book?
Yeah. So this is the Aphrodite 4 that we are mentioning now, no? Hypergonadotropic
Yes.
hypogonadism.
Yes.
So again, so these are the patients in which you would want to optimize, and we generally have very little solution for these patients. Small testes, high FSH, what to do? So according to many studies, they have given HCG in these patients also, then waited for 3 months, and then seen if the testicular size has improved, if the serum testosterone has improved, and if it has happened, then you can go for a micro-TESI in these patients, or then you will have to add FSH in these patients for at least 3 to 4 months, and then again plan for surgery. I mean sperm retrieval.
So, Dr. Manu, in your experience, did you do this, that in initial TISA, we did not get sperms, then you
Yes.
thought to give gonadotropins, and then you planned a micro-TESI?
Many patients that we've coming now, because the only problem with our practice is that the patients don't stick with us. We start the treatment and then they don't come back. So my suggestion to everybody over here is to counsel the patients well at both the ends, as far as the fertility community goes, as far as the andrology community. But 3 patients in the last 6 months, we've been able to retrieve sperms who were given HCG for 3 months, and in 2 of them they also received FSH for another 3 months. So yes, there is a chance of sperm retrieval.
What dose you were giving? What were the dose?
The HCG was started according to the weight of the patients also. Normally we give 2000 units subcutaneously weekly, and we have given up to 5000 also weekly for HCG, and for the FSH we are giving 250 international units twice weekly.
250?
Yeah.
Okay, usually we start with the 75 or 150, but here
Yeah,
it is
150 is the standard, but I think both of these patients, the weight of the patients was more, so we gave 250 directly.
And twice a week?
Twice a week, yeah. It can be even twice or thrice a week.
Are you measuring the testosterone levels to know the response?
Every 3 months we have to measure the testosterone, and sometimes, although the books say that the testis size also increases, but I've never seen that increase.
Okay. Sir, also there is a question saying, and I think I also need a little help from you to understand this, that in Aphrodite group 4, when we already have a high endogenous FSH, why are we suggesting that further increasing the FSH, supplementing with FSH will give us a better result?
Actually, this is very ambiguous. I really don't have an answer for this. Sometimes male infertility management becomes very confusing. Sometimes people have given exogenous testosterone in terms of gel and injections, and then also the sperm count has improved when it should have gone down.
Yeah.
So this is very ambiguous, but this study, this classification, this stratification is very welcome. So the moment we see a patient, we can categorize them in this particular classification and then manage accordingly. Abhi tak what was happening was there was a lot of confusion in your busy practice when somebody is coming with the high FSH, somebody is coming with a normal FSH and a low testosterone. So it was very confusing. But I think through this journal club and through everybody's getting educated about this, we will stratify the patients right there in the OPD and make our own flow charts and then follow them accordingly. Treat them and follow them accordingly.
I personally also feel that, sir, this helps us in guiding for investigation, like which male you need to go for genetic testing, which male you just need to start supplementing. And it doesn't mention about the role of antioxidant supplements.
Actually, this is basically dealing with the hormone milieu of the males, So that is why they have not discussed any nutraceuticals. They have not discussed any clomiphene. Because that is not important here. What is important here is to kind of know in what patient what needs to be done and what has been done and what has affected for better sperm retrieval, either in the ejaculate or via the procedures like TISA and TESI. So this is just a classification, Dr. Nisha.
Yeah.
But a very good one at it.
Yes.
I
So
think
there's
it kind of differentiates that who would benefit with
Yes.
standalone HCG to start HCG followed by
Yeah.
FSH, and those who would benefit with FSH standalone and
Yes.
then maybe need HCG, and those who would only need FSH. So I
yeah.
think this kind of helps us in categorizing that what comes first.
Like Aphrodite 5, they've said that FSH will help, So yeah, like super stimulating the sperm production by giving more FSH. Now I don't know whether that will have a contradictory role. So we have not seen giving FSH in patients who have normal parameters, and unexplained infertility. So this also needs to be taken with a pinch of salt. Just don't. You should not blindly follow what they have
And
done.
sir, it is not mentioned any studies in Aphrodite
Yeah.
5. They have not given any evidence.
I
Mhm.
think
Towards these.
every, yes. So there is another question, sir. Maybe Dr. Shweta and Dr. Manu can take any evidence on what should be the dosage to begin with for unexplained group? The fifth group. Any dosage, any evidence
I
to suggest?
personally don't give less than 150 if I have
Yeah.
to give.
Yeah, I also believe that 150
I
is.
think 150 is the standard dose for
Yeah,
males
that's standard.
for FSH.
So there is another question, sir. There is normal FSH, normal testosterone, isolated high LH with abnormal semen analysis. What should be the way ahead? I think
I-
the LH high doesn't work like in females. In PCOS, you have high LH. Maybe I think
You can take it. The correlation should be with FSH and testosterone and
Testosterone.
parameter.
So this is like I think you can get the sample repeated and then involve an endocrinologist. No, they'll rack their brains to find out why only LH is increased. As of now, I
I
can't think of
personally
any.
feel, sir, like in like in normal females, we talk about LH and FSH. We see high LH in PCOS group, but we also see high LH in the poor ovarian reserve group, where the eminent failure is going to happen. The reserve is going down. So maybe this is an indication that the sperm parameters are going down.
LH generally has hand in hand with testosterone. So it is very. I've not seen somebody having a higher LH and a lower testosterone or a normal testosterone.
So
So
the
it,
next
Anu,
question.
if by your therapy, if you see excessively high testosterone levels rising, would you now reduce your dose?
yeah, definitely. I mean, reducing sometimes you'll have to stop it also.
Especially HCG?
Yeah, yeah, definitely. Yeah, because super testosterone levels, our patient will have lot of problems with that also. There is behavioral changes, and patient is not his normal self. There's a very high testosterone, and also everybody's educated now. They are always seeing things on the internet and all that, so they would come and hamper you with this. Why is it happening? And then sometimes there is a fluid overload in the body also. I've seen that. So we
I
have to
have
be very
seen,
careful.
I have seen one of my patient with hypo, and the moment I would put him on HCG, he said, I have gynecomastia, and he would stop.
Yeah.
He would say, long term, I would have gynecomastia. There was a question that, Bhavani, did you come across use of clomiphene in group 5?
No, ma'am. This particular review is mainly on the use of gonadotropin regimens in these 5 groups, and they have made a mention of clomiphene and aromatase inhibitors in the discussion part, but that too only in group 2, which is abnormal semen analysis parameters with normal FSH and testosterone. So in group
Which
5,
is So basically, clomiphene is being given empirically in this largest segment of patients. Group 2 is the largest segment of patients that we see. Everything is normal. All the hormones are normal, but still there is a problem. So clomiphene, I think it's the like the bone of everybody gives clomiphene. If there's nothing to give, we used to give clomiphene earlier also. So it is still being given. It has not stopped, but there is no rationale. I mean, studies would contradict each other every day.
So there is another question which is like asking what is the meaning of unexplained male infertility? How do you define unexplained male infertility? I think all the parameters are normal. Yeah.
All the semen parameters are normal, all the hormones are normal, the testicular size is normal. That is what is suggestive of unexplained. And most likely, if then you go for these DNA fragmentation tests, and then if you find poor DNA fragmentation and all, then you can say that this is one of the causes. We don't usually do it unless it is long-standing unexplained infertility or bad obstetric history and all those things.
Dr. Bhavani, maybe you can answer this. How have they given and followed FSH in group 2? You said doses from 75 to 300. Was there any specific group they have said that these people received this much, these people received this much? No? I don't think so.
Yes, ma'am, I can just, they have not exactly mentioned in this study, but I would just like to show one flowchart by the Steve's et al. Study, if I can be allowed to share the screen.
Yeah, sure.
Yeah, just 1 minute.
While Bhavani is trying to share her screen, I would request everyone again to download the Kahoot app because we are going to start with the quiz in few minutes.
It would be good if you have it on your
Ma'am,
mobile.
is my
See it on your laptop and do it on the mobile also is a good option. I always do that way. You work faster.
so is the screen visible, ma'am?
No, you are visible, Bhavani.
Okay.
Can
Just
you? Who is there? Shivam is there, right?
Yeah,
Yeah,
Shivam.
ma'am.
Shivam, can you let us share her screen?
I just
Yeah, ma'am. You can share the screen.
okay,
Yeah.
thank you. Is it visible now?
Yes,
Yes.
yes.
So as you can see here, this is uh, the regimen for idiopathic oligozoospermia, that is Aphrodite group 2, where they have measured all the parameters initially. And if FSH is less than 8, they've given recombinant FSH 150 units subcutaneously thrice weekly. And if no pregnancy, they've measured semen analysis, testosterone, pre-testosterone, SHBG after 4 months. And if semen parameters have improved, they have continued. If they have not improved, they have gone for ART. And if they have semen parameters have improved, but testosterone levels are below reference ranges, they have added HCG.
Yeah, so that,
1000.
yeah, I was just telling this only that monitoring testosterone, I think, is important, right?
Yes.
Though I think our shortcomings would be that we won't be able to do SHBG, right?
No, we don't have to do everything. I mean,
Yeah, we
just
don't
the
have.
total testosterone is sufficient to monitor.
Perfect. So, Dr. Nisha, do we have some more questions?
Yeah, we do have. Sir, is there any role of inhibin to prognosticate for TISA?
Honestly, I am not aware of it.
Yeah.
Very
Then there
honest.
is another question. There are studies where they are using letrozole 2.5
Yes.
milligram daily for 3 months. When the testosterone to E2 is less than 10 in obese men, does BMI play a role in deciding treatment with letrozole?
Yes.
Yes.
Yes, it does. Obese men and a lot of people are obese now. I mean, so, and letrozole is like the new drug of the last 2-3 years that we've been giving. We are getting the testosterone and estradiol, and we are using the calculators to find the ratio. So I think it is beneficial. Now, how much live birth rates it has produced, I cannot say, but definitely the sperm parameters have improved.
Dr. Manu, I had one question. I always keep hearing Dr. Ranjit from US.
Yes.
That he
Yes.
says he gives alternate clomiphene with letrozole to increase the intratesticular testosterone.
Testosterone. Yes.
So,
Yes.
do you do these regimes?
Well, it does increase the ITT, and obviously ITT is the most important thing in spermiogenesis, in spermatogenesis.
So how do they give it? Like 25 milligram clomiphene and the next day 2.5 milligram letrozole. How is it done?
I'll have to check it, Dr. Shweta. If I know about it, but I don't know the exact dosage and the schedule that they give.
And my one more question, when we are giving
Mhm.
clomiphene, earlier we would give 25 days on and 5 days off, my old days
Not,
teaching,
yeah,
not any
not
longer.
required. No, we
Now,
give
do
it directly for
do
3
you
months.
counsel them for any eye, visual
Yes.
symptoms? You do.
Yeah.
Okay.
There is fluid overload, and there are mood changes also sometimes, and so, but I've never had a really a patient coming to me with a complication associated with clomipene.
I only remember, I think one patient of mine who said I'm having some visual symptoms, but yes, I also don't recall,
Yeah.
any of the patient coming with these symptoms. Dr. Nisha, any more?
No, yeah, one very, very good question. Actually, we heard a very good talk from Dr. Preeti some time back, role of AMH. And Dr. Meshwa now wants to know any role of AMH in hormonal evaluation for male infertility. Dr. Manu?
I think this journal club has been presented at the Gangaram Fertility. I think Dr. Shweta would be telling you more about it. I'm aware of it.
Dr. Shweta, role of AMH?
No, I'm not.
I think we all need to read about
Yeah,
it.
we all need to read even 17-hydroxyprogesterone
Yeah.
in males. I won't be able to comment on it.
It's really,
What we will
really,
do is, Dr. Nisha, these two questions can be taken up, and in the group we will put the answers.
yeah. So
Dr.
let me
Bhavani,
just,
can you take up these two questions?
what I'll do is that I'll click a picture of this and then maybe we can put it later. Okay. That is wonderful. Very good. Young Turks, I am proud of all of you. We did very well. And Bhavani, it was an excellent presentation. Thank you, Dr. Manu. Thank you, Dr. Shweta, for taking this initiative.
I'm very happy that first journal club we've crossed 100. So
Yes,
let's
yeah.
be cheers for everyone. I would definitely like comments, suggestions. All of them are most welcome. We can always improve. We will do the next journal club after 15 days. Is there any volunteer right now? Please put it in the chat
Somebody
box.
would like to give
This
their
is
name.
journal club just for all of us. Nobody's comparing anyone, nothing.
Yes.
So, and please, all of us, we need good articles. If you come across a good article, put it in the group and I will, we will scrutinize it and we feel that it is for the journal club, we'll get it presented. So do we have any volunteer for the next session?
Somebody volunteer, please.
Then I will have to pick any of my ex-fellows.
No. Pick
I
from
don't
this.
want to do that. I don't want to do that.
Dr. Shweta, pick from this. I think Sirisha, can you unmute yourself? Sirisha KVS.
Shrisha, ma'am. Ma'am, we need to give the access.
Yeah.
Can you give the access? You give access to all now.
Now,
Access
yes.
to all?
We can
Okay.
have the cameras on so
Yeah.
that we get to know also each other.
Done, ma'am.
Sirisha, can I nominate you for the next journal club discussion? Okay, Suhani is there. From Suhani Chandra, there is a message from Suhani. She wants to present
Yes, ma'am.
next. Suhani?
Hello.
Yes, Suhani. Please
Yes.
go ahead.
Hi, this is Sirisha.
So there is a tie between Sirisha and Suhani. Who's going to
Okay.
present now?
Dr. Suhani has been the first, so it took me 1 second late. I will be after.
Okay, so we can have Dr. Suhani after 15 days and then we can have Sirisha in the next one.
Yeah,
Okay.
sure.
The next two are booked.
Then we have our cameras on if possible and then we can take one picture and then we go to the much awaited second part of this. So is there someone to take a picture? I will do that.
Shivam, I think.
Yeah, Shivam?
Yes, ma'am.
Can you take a picture of all of us?
Sure, ma'am. Just open your.
Give honest opinion, okay, after this in the group.
Sure, ma'am.
It's so good to see everyone. So many faces I can recognize.
So, ma'am, on the count of 3, right? 3, 2, 1. Done, ma'am. 3, 2, 1. Next. Yeah, done, ma'am. Thank you.
Thank you so much. And thank you, Dr. Nisha. It has really been wonderful and hard work from you to make all these people join in. Now we will move on to our next much awaited.
Shweta, ma'am. Wait a second.
Yeah. Presenting. So Dr. Manjusha, are you there?
Shweta, ma'am, should we remove the mute and unmute power?
Yes.
Yeah. Thank you.
We can put the quiz logo now.
Sure, ma'am. Manjush, ma'am, you need to just start with your PPT once, right? The instruction PPT.
Yeah, we need to play on the phone. Dr. Shweta, can we tell everyone? Okay, fine.
Yeah,
Instructions
I'm
are there.
coming to it.
Yeah,
Okay.
firstly,
Thank you so much. Thank you, Dr. Pankaj sir and Dr. Shweta, for conceptualizing this wonderful thing and making me a part of it. And thank you, Nisha, and thank you, IT team, for making all this happen.
Thank you.
This really has been a learning exercise, not just on a medical front, but also legal and also the technical aspects. And today we are going to debut with the ART law and fertility practice. Before we take off, yes, so this is a first time thing. We are trying to learn how to work on Kahoot. And yes, I would like all of you to open up the Kahoot app on your mobile. Everybody, please open up the app. And then this is a checkered this thing at the bottom of your screen. You click on this, and then it will ask you for a pin. You've got to enter the numbers shown on the Kahoot screen as soon as the quiz begins. Once I'm done with the instructions, the IT team will start sharing the screen, and on the Kahoot screen, you'll see a pin number. You got to enter it on your Kahoot app, and then it will ask you for a nickname. So we would like you to enter your mobile number, not your name, because then it will become easier for us to connect to you with your mobile number. And we would request you all to join very quickly, because once the
Mandisha,
admin...
can you share that one flyer we had made so that they can read simultaneously?
sure, ma'am.
Yeah.
The flyer, Mr. Shivam, can you share?
And this Kahoot
I'll stop
for
sharing so
everyone.
that you can
It is for
share.
everyone. It is not just for Young Turks, it's for every member of IFS.
Yes. So let me just complete with the instructions, then I'll stop sharing. Okay. Yes. So we have to join quickly, because once the host locks the quiz, you'll not be able to enter. Each question would stay on for 20 seconds. We got to answer very quickly but correctly, because you have been assessed for speed as well as accuracy. And then at the end of the quiz, we'll identify 5 top scorers who would move on to the grand finale, hopefully in November. So we got to tighten up our seatbelts and let the adventure begin. Now, may I ask the IT team to please, I'll stop sharing and I'll ask you to share the...
Done, ma'am.
Yeah.
So just to interrupt and just to introduce this concept, thank you, Dr. Manjusha. So there are different platforms of learning. It can be a very serious platform. It can be not so serious, and it can be fun. So Journal Club was one. The other way we thought that where everyone could participate, not just Fertivision, where just limited people come. So monthly there would be an online quiz. And we don't have Dr. Arun Arora, who's the mentor of this, quiz committee. Also, he would be the North coordinator. Dr. Manjusha would be from the Central, Dr. Kokila Desai from the West, Dr. Rajapriya from the South, Dr. Rohini and Dr. Nikita for East and Northeast. So each one zone coordinator would be making questions and putting it in the Kahoot. A huge question bank would be made. So this is not only Kahoot. And at the end of this Kahoot, we will be choosing 5 top scorers, and they would be getting an e-certificate for this particular Kahoot. And then later on, I think Dr. Manjusha, can you just tell me that you have in mind that by November, you wish to do zonal, you all? What have the quiz committee?
This is not about the zonal quiz. This is about the pan-India quiz. And we'll be holding one quiz every month. And the top 5 scorers of each quiz between now and October, they would be invited to participate in the finale, which we propose to be held in November. So as things unfold, we'll be evolving. And then if anything changes, we'll be informing everybody.
And the next meeting, Dr. Arun Arora sir would be there, who's the mentor, and he also has brilliant ideas. So I'm sure this is the first attempt. And Dr. Manjusha told me that if there are any hiccups, then I said no, I will not announce, because I think there will be no hiccups. So are you guys all ready? Can we have a thumbs up on the chat? If you are ready, then we can start. Dr. Manjusha, the forum is all yours.
Thank you, Shweta. Okay, so I'll start sharing my screen. Okay, So the admin wants me to repeat again that once the screen asks for a PIN, please enter the number shown on the Kahoot screen, and then it will ask you for a nickname. Please enter your mobile number and not your name there. And as soon as the quiz begins, you will get the question will be on for 20 seconds. You got to be quick and you got to be accurate. So I would now request the admin to start with the quiz, and here we begin. Okay, so this is the PIN. Please enter 700616 on your mobile. Yes, we already have about 10 people. I wanted the list to go up to 100. Ishika and Shri, please enter your mobile numbers. We don't want in the chat boxes, we want it on the Kahoot screen. How many are there? Can we Gorakhnath Giri, please enter the number on your Kahoot screen, not in the chat box.
Let's give 2-3 more minutes.
Yeah.
I hope everybody is seeing the PIN 700616. Anybody having a hiccup, put the question in the chat box.
Shri, please enter your mobile number.
Ishika, you also need to put your mobile number. Yeah.
Kavita, you have to download Kahoot on your mobile app. If you're not on mobile, please log into kahoot.in on your Google.
Ishika, you are still not entered your mobile number. Ishika needs to put her mobile number.
It will be easier, if you see on your laptop and answer and log in from your phone, 2 devices. I think it will be easy.
Tanu, please enter your mobile number there.
Or you can even do one screen. One screen is also okay.
Tanu and Ishika, they both are still. Instead of nickname, you may reload it. If you are, see, Ishika and Tanu, you cannot, if you cannot delete it, reload it.
You know what? No, you end the game and you log in again.
Reload it, yes.
You exit, end the game and enter again.
NJ also. NJ, please enter your mobile number.
Sometimes this name will remain Ashika, but she would have logged it from a mobile because it happened to me in the afternoon. My name kept showing.
We have 43 people, 44. Let the number grow, because once he logs the quiz, no more people will be able to enter. We were 85 people on the Zoom platform. We only have 46 here till now.
Aarti K. Jairaj, beta, you need to change it. You need to make it your mobile number because it is easy to identify. So no, the nickname only where you go out, you reload the quiz, you log out and then reload it. Okay?
43 people are with. इशिका, आप ऐप से बाहर निकल जाओ, उसके बाद दोबारा लॉगिन कर दो ऐप में. I think if she's not able to do it, we can let it be.
It's okay. The name, instead of mobile number, it will show with name. Then we'll have to check and ask her number.
Yeah. So here we are at half a century. Kavita, when you open the app there, you will find a screen which asks for a PIN number. You have to put in 700616 in the PIN number. Then it will come to the screen where it asks for your nickname. Then you have to enter the nickname.
So see here, there is a small box here. Can everybody see? There is a small box here with the 4 squares. Like a checkers box with red, blue, yellow, orange. There you have to go. Let's go. This small box over here.
Where are the other 38 people? Please join fast. Dr. Shweta, shall we begin or should we wait for a few more minutes? Dr. Shweta?
Yes, I'm there. I think we can start now.
Yeah. Mr. Shivam, would you be happy to start off?
Should we log the quiz now?
But are more people joining or no?
No, ma'am. Actually, 51 is there.
Okay.
52, yeah. So we can log this. Done, ma'am. So should we start?
Yes. So tighten your seat belts and get ready for the adventure. So we're going to talk about the IFS quiz. 3, 2, and 1. Yes. So as per the ART Act, the minimum equipment required for level 1 clinics, all except microscope, centrifuge, laminar flow, and refrigerator. Be accurate and be quick. Okay, right. So 39 people have said laminar flow, which is the correct answer. 10 people have got it wrong. They say the refrigerator. Okay, can we move on to the next question, please? 3922 was the fastest. Okay, so Shivam, can we move on to the next question? The ovum donor, as per the ART law, should fit the following criteria, except she should be more than 23, she should not have donated ova in the past, she should not be more than 35, and she must be married. Quick. An ovum donor should fulfill all the criteria except. Right. So 39 people have said she should be married, which is correct. So can we know who is leading? Okay, 3922. Yes, 3922 happens to be fast and clear and accurate. Okay. So can we go on to the next quiz, please? Okay. So question 3. Under the PCPNDT Act, which form must be filled and submitted online by all those who are doing antenatal scans? Form D, E, F, and G. Easy question, right? Form F. 39 people have got it right. Great. Swapna, please don't type in the chat box. This is a quiz. You don't want to tell answers to everybody. So 5705 is the top climber. Let's see if the others can catch up. Can we have the next question, please? Right. So if there's a couple who is seeking IVF as per the ART law, they must meet the following criteria except age of the female above 21, age of the female less than 50, age of male less than 55, and she must be currently married. Soumya Ranjan, you have to add on the Kahoot app. Soumya, please log into the Kahoot app. Okay. So most have got it right. She must be currently married is not the correct answer. Can we move on, please? Okay, 75705 remains the top scorer. Okay. consent of the husband is a must for MTP, LSCS, tubectomy, and none of the above. Can the wife undergo all these alone without asking for her husband's go ahead? 52 people have answered, 54, 55, yes. So almost all have got it correct. 40, none of the above. Can we move on? So 5705, you are really a very sharp child. You are working so fast. I'm impressed. So, which is false about gamete usage? A woman shall not be treated with oocytes from more than one donor in one cycle. A clinic is not eligible to mix semen from two males. Appropriately screened healthy women can donate her oocytes for money, and law permits using gametes from friends or family, which is incorrect. Okay. 14 people have said D also. No, this is not that. The answer is C. Appropriately screened healthy women can donate her oocytes for money. No, we cannot donate for money. It has to be altruistic. No, you can't donate for money. Sorry. Next slide, please. 5705 is really short. Others, please catch up. You got to be fast and accurate. Okay. According to MCI, for how long should the indoor non-MLC case records be maintained, preserved? Is it 3 years, 6 years, 25 years, or lifelong? Non-MLC indoor case records. Okay, so this almost looks like a fastest finger first, and there is no consensus amongst all the girls. 3 years is what MCI says. Can we have the next slide? Okay, now we have another top scorer, 36323. Now, others, please buck up. Okay, now this is tricky. A 16-year-old is brought by her mother for amenorrhea and is found 8 weeks pregnant. So what do you do next? You refer her to a medical college because of medical legal concerns. You do an MTP unofficially without paper documentation. You ask the mother whether or not she wants a police case, or you start treatment and inform the juvenile police. So this is a 16-year-old brought by her mother who is found to be pregnant. Okay, so you all concur there. 45, yes. 45 people say that the answer is start treatment and inform the juvenile police, which is correct. I'm so proud of you girls. Let's see who did it fastest. Okay, 5705, congratulations. You have caught up again. You are up the scoreboard. Okay. The sperm or oocyte donor shall be tested for the following communicable diseases except HIV, hepatitis B and C, syphilis, and HPV. You will test a donor for all these -1. Which one is that? You've already answered. Everybody's answered. By Joe, well done. So almost all of you agree that it is HPV. Well read, girls. I'm so proud of you. Can we have the next slide? Okay. 5705. Wow. So what's wrong with this movie, Wiki Donor, in view of the new ART Act? There's nothing wrong? Is it filming a sensitive topic unethical? It is illegal to hold a get-together for babies born through ART, or gametes from one donor cannot be used for different aspiring couples. Which one is incorrect? No, which one is, yeah, what's wrong with the movie? Okay, so you all agree that one person cannot be fathering the whole city. Well done. Let's see who got it fastest. Okay, 75705. Other girls, please back up. Be fast.
There could be guys too.
Yeah. Girls and guys, yes. Okay. So if a 17-year-old comes seeking contraception, should you prescribe always in order to prevent pregnancy? Should you assess her maturity, exclude abuse, and prescribe if appropriate? Should you inform juvenile police under POCSO, or should you scold her and inform the parents? Okay. There's one person who wants to scold her. Oh my God. Okay. Right. Well done, girls. We are drawing to the close. No, we are midway. This is 12th question. So, which ART is permissible in the state of Delhi today? Donor semen IUI, IVF ET using donor oocytes, surrogacy, and all of the above. What all are permissible legally in the state of Delhi as on date? Great. So almost all have got it correct. Well done. Girls and boys, well done. Okay. So 13th question. Which of the following is true regarding registration of an ART clinic or bank? The application should be made by the ART bank in Form 15. The registration fees for level 2 ART clinic is 5 lakhs. Registration fee for ART bank is 1 lakh. And registration fee is not refundable if the application is rejected by the appropriate authority. Which one is true? Girls and boys, you need to read up the act. The correct answer is registration fees is not refundable if the application is found rejected. Next slide, please. ACCC has moved down. Okay. Now, which of the following is not true regarding collection of or usage of gametes? Posthumous use requires prior consent of both parties. Embryos can be preserved by ART clinic for use on same recipient. All formed follicles should be retrieved from the donor, and commissioning couple should provide 6 months insurance to the oocyte donor. Which one is incorrect? Okay. So 36 people have given the correct answer. The commissioning couple has to be given 1 year of insurance. Well done, ACCC. You are way up now. Okay. So in the ART law, a gynecologist means somebody who's in a PG in obs-gyne with additional qualifications except experience of more than 2 years in reproductive medicine, 3 years training in registered ART center, somebody who has performed 50 or more oocyte retrievals under supervision, and DM or fellowship in reproductive medicine. Which one is incorrect amongst these? Great. So the largest proportion knows it. The experience of more than 2 years is incorrect. The correct answer would be more than 3 years. Can we have the next slide? Well done, 6342. You are at the top now. Try and maintain your lead now. Others also, please pack up. We want to have 5 winners. So, which of the following is false about embryo usage? False. Embryo of one couple cannot be used for another. During ET, a maximum of 3 embryos can be placed. Pre-implantation genetic diagnosis can be done routinely, and embryos cannot be shipped without permission from the appropriate authority. Which one is false? Great, great. We have a very learned bunch of girls and boys, isn't it, Shweta? Most of them are getting most of the answers correct. Well done.
Yes, absolutely.
So 5156. I'm so happy to see you on top. Well done. So which of the following is not an offense under ART law? Not an offense. Shifting stored embryos to another clinic without permission, abandoning children born through ART, selling, purchasing, importing human embryos or gametes, and using donor ovum in a commissioning couple with female under 25. Which one is not an offense? Well done. 41% know the correct answer. But 4 people feel that selling gametes is not an offense. No, we need to learn it there. Okay. Now 2169 has made a comeback.
Last 3 questions, right?
Yes.
4.
As per the surrogacy amendment rule, who is legally eligible as intending parent or parents? Legally married, medically ill woman of 20 and a man of 25, a gay couple 34 and 36, a widow and divorcee single woman intending to use donor semen, and none of the above. Who is legally eligible by surrogacy? Great. 36 people know the new amendment. Wow, I'm impressed. Can we move further? Okay. 74999. Wow, 3 in a row you have got correct. Back in the game. Great. So this is the penultimate question. According to the ART Act, level 2 clinic can do all except perform screening and registration of semen donors, surgical retrieval of male or female gametes, handling the oocytes outside the human body, and transferring the embryo into the reproductive system of a woman. Which one can an ART clinic not do as per the Act? Great. 46 people have answered correct. But I wonder why have 5 got it this wrong? ART level 2 clinic will be handling oocytes outside the human body there. Okay. Next, can we move further? 8 players have reached answers quickly. Wow, great. But 5705 remains in the top. So here comes the last question. Identify the correctly matched forms required under the ART Act. Form 1 is the registration of ART bank. Form 2 is the registration of the clinic. Form 3 is certificate of registration from the appropriate authority. And Form 5 is consent signed by the couple. Which one is correctly matched? Pretty, huh? Yeah, people seem to be differing. Girls, you'll need to remember all the forms because they're important for your theory exam as well and practically when you go into practice. So now that we are end of this, can I briefly share my screen and tell the answers to everybody so that they learn better?
Ma'am, can we have the results now?
Yeah,
Okay,
yeah.
okay. Before
Yeah.
that, we can have the results.
Yeah. So here is this podium, ma'am.
Wow. We need number 4 and number 5 also.
Can we have the other two, fourth and fifth also? Yeah, runners up.
Yeah, I'll give me everything. I want to click a picture.
Yeah, ma'am,
No,
I have
give me
already
5
done.
also.
I'll share.
The 4th, 5th also.
Ma'am, I'll share. I'll share.
Okay. So congratulations, winners.
I have.
And I hope you all enjoyed this quiz as much as we enjoyed putting it up for you. I think I would like to briefly take you through the answers. Although we have had them all, I'll still briefly take you through them. Okay. So minimum equipment for level 2, we do not need a laminar flow. The ovum donor must be above 23. She should have never donated ova in the past. She should not be more than 35. And the wrong thing is she should be married. No, this is not correct. Any unmarried girl, any single woman, they can also donate their ovum for an AR. Okay. Now, the form F is the one which has to be filled by the ultrasound clinic. The genetic clinic also has to fill form F. The genetic lab has to fill form E and the IVF center has to fill form G. We have to know these forms, they're important. This is what the form F looks like. I would suggest that you all go through the forms, what all they contain. Now, the couple seeking IVF as per the law should meet the following criteria except the age of the woman should be between 21 to 50 years and age of the male partner should be below 55. In case of a woman, even an unmarried woman or a divorced woman, she can also undergo an ART. But the same is not true for men. An unmarried or single man cannot go in for a artificial techniques through a surrogacy or whatever. Now, the consent of the husband is not needed for MTP because the Act allows reproductive autonomy to women. For LSCS, any two people can be witnesses, need not be the husband. And for tubectomy, the woman alone can sign. She only needs to say that she has also talked to her husband. That's all. Now, coming to the which is false about gamete usage, a woman cannot be treated with more than one oocyte from more than one donor in a single cycle. Okay? A clinic cannot mix semen from two males. We can use gametes from friends and family, but a donor cannot be paid money as per the ART. And coming to how long should the indoor records be preserved? Yes, in India, there are no definite guidelines. The hospitals choose to follow their own patterns. But as per MCI, the indoor records should be preserved for 3 years from the date of commencement of treatment and the outdoor for 2 years. Medical legal cases should be maintained till the case is finally disposed of. And for PCPNDT, again, the documents have to be preserved for 2 years. This is what MCI says. Okay. And regarding a 16-year-old pregnant girl, we should ideally start treatment and inform the juvenile police because this comes under the purview of FOXO. This is the FOXY document of August 2021, where they say that we don't have to ask the mother whether or not she wants a police case. She will always say no. We've got to inform the juvenile police, and then if there's an indication for MTP, we have to take the consent of guardians because she's only 16. And it happens to be our legal responsibility to inform the juvenile police. And ignorance is never a plea in the court of law. And this you all got right. HPV testing is not done before any taking any gamete donations. Wiki donor, you all got it right. Gamete from one donor cannot be used for different couples. Okay, now coming to this tricky question. What if a 17-year-old comes and asks for contraception? The problem here is that FOXO considers sexual activity at under 18 as inappropriate. Now, this girl is technically a minor, but these adolescents today deny seeking parental knowledge. And of course, confidentiality matters. And if we happen to deny contraception, we are going to increase the risk of pregnancy and unsafe abortions. The thing is that the current law, modern day freedom, and medical safety are not in sync. And so the clinician has to take the task. So the important thing we have to do is to exclude abuse, ascertain that she is mature enough to understand the consequences and make a sensible choice. We've got to be non-judgmental, otherwise we'll lose the window of opportunity. We have to tell her about the risk of STD and pregnancy. We have to educate her about reproductive health. We've got to tell her about the use of barrier along with another reliable contraceptive and encourage her to seek help. So in totality, we've got to assess maturity, exclude abuse, and prescribe contraception if appropriate, even though she is just 17. Now, this requires no explanation. Yes, coming to this, which is true about registration of a clinic or bank. The ART bank application is made in Form 4. The fee for the level 2 clinic is 2 lakhs, not 5. The fee for a bank application is 50,000, not 1 lakh. And the fact is that registration fees is not refundable. Although if you have to reapply, the same fee would hold true. You don't have to pay again. But that fees will not be refunded if the application is rejected. This is from the budget. Okay. Now this I've already told you. This collection or usage of gamete, the commissioning couple have to provide 12 months insurance to oocyte donor, not 6 months. So this is wrong. This you all got right. A gynecologist means a PG in obs-gynae with experience of 3 or more years in reproductive medicine, as per the law. Reimplantation genetic diagnosis is to be done only when indicated. It can never be a routine. This was clear. We can use a donor ovum in a woman under 25 because the commissioning female needs to be between 21 to 50 to undergo an AR. So using a donor ovum in a woman under 25 is not a crime. We can use it if she needs it. And this is as per the surrogacy amendment. A single woman also can use surrogacy with a donor semen. She doesn't have to be currently married to undergo surrogacy. And this, of course, requires no explanation. A level 2 clinic can do all but cannot perform screening and registration of semen donor. So that's it. You may take pictures of this, but this is easily available on Google and everywhere. Which form is to be used for what? Form 1 is for applying for the clinic. Form 2 is for the bank. Form 3 is the certificate issued by the appropriate authority. Form 4 is for a reappeal. Form 5 is to make a complaint. Form 6 is the consent. Form 7 is for IUI with husband semen. Form 8 is IUI with a donor semen. Form 9 is for freezing embryos. Form 10 is for freezing gametes. And likewise. I think we can leave it for the next one. Thank you so much. Thank you.
Thank you, Dr. Manjusha. Thank you, all the participants. Can we have the names of the participants now? Since you all know. And Dr. Shivam, can you just project that numbers and then people can identify themselves?
What, ma'am?
If you can share that screenshot where the
Sure,
number.
ma'am. Sure, ma'am.
Yeah. So congratulations. This was also an AI-based learning platform and Kahoot is one of them. I think over 50. How many participated? About 50 or 55, right? That was excellent. Please give your feedback. We'll just, if everyone, you can just tell your names, the top 5.
It must have been when you would not have been into like
Can we unmute all?
Yeah. I think this 98117757 is 705. Dr. Vandana.
Also it was IUI was
Dr. Vandana.
Done, ma'am. Done, ma'am.
Hello, ma'am. I'm Dr. Vandana. Hello.
Can we also see you, Vandana?
Which
Yes,
place?
ma'am. How, ma'am? I'm Dr. Vandana and I have joined Dr. Sonia Malik this year. I'm working with her.
Excellent.
And Nova.
Acha, Dr. Vandana, congratulations. Who is the second one?
Ma'am, this is Dr. Binakshi from Calcutta. I have finished my FNB from MAMC and currently I'm a consultant at Institute of Reproductive Medicine in Kolkata.
Oh, lovely. My parent institution. Okay, who's the third one?
Ma'am, I'm Dr. Jasneet. I'm from Chandigarh. I'm working at Milan Fertility Center, Chandigarh.
Yes.
Congratulations. Thank you, ma'am.
Fifth, the top 5.
No, the fourth one, 8333.
Ma'am, I'm Dr. Manisha. I'm currently doing MCH in Reproductive Medicine at IGMS Patna, ma'am.
Excellent. Congratulations. And 9265. Okay, so I think we'll identify. Congratulations, all of them. Shivam, can you note down these numbers and we can take their email addresses and then give them the e-certificate?
Sure, ma'am.
Yeah. Okay, thank you, everyone. I think now we wind up.
I think Dr. Kokila would be talking about the next quiz.
Kokila, are you there?
Dr. Kokila, are you there with us? Dr. Kokila? So as she suggested that she would be taking the next quiz on endometrium, and we plan to hold it on the last Friday of every month. So the last Friday of May, I think, should be the 20th. When is the last Friday? The last Friday of May. Dr. Kokila will be taking a quiz on endometrium.
Dr. Shweta, can we combine these two things together again? Journal club and quiz?
I will let you know. I'll think about it. If everybody says that doing it together is better, then I'll do it.
Yeah, sure.
Because I want everyone to participate in the quiz, not just Young Turks. And everyone is most welcome to join Young Turks Club, but Young Turks will present.
Okay.
Okay, thank you, everyone. Thank you very much for being here.
Thank you, Shweta. Thank you for
We crossed
this
100 people in the Young Turks and we crossed 50 in the quiz. let's hope to
So-
double up in the next
So
session.
we have Dr. Monu, who was in the top 5, working in Krista IVF. So congratulations and congratulations to all the participants. See you soon.
Thank you.
Bye.
Bye. Bye. Bye.
Yes.